All right, why don't we go ahead and get rolling? Thanks everybody for joining. A few kind of updates on some old topics. I think today I don't think there's anything that's terribly new or exciting necessarily. So we'll kind of jump in and then kind of move forward from there. So as we look at incidents, it's interesting. Most of the region, we talked before about the doubling rate and how Monroe County had a fairly long doubling rate, which meant it was taking about 6 weeks for the number of cases per day to double over currently. If you went really one county in any direction, that doubling rate jumped from anywhere to 3 to 4 weeks to 1 to 2 weeks. If you got into Genesee, Livingston, Wyoming, and the like. All of those are actually seeing, pretty much every area is seeing an increase, meaning prolongation of that doubling rate, which means the cases are not happening as quickly, which is good. If we look at case rates 14 days ago, across the region, we were seeing anywhere from probably a low of about 4 to a high of about 9.8, I think, in the surrounding counties. That has now diminished to now our incidence rate is down back around that 4 or 5% in average across the 9-county region in the Finger Lakes area. So overall, we're starting to see a little bit of a plateau. Now that, if you look at some of the other predictive modeling, now I will say the U of R predictive modeling still is showing a steady but flattened increase over the next couple of weeks, and the worsening somewhere in that middle to end of October kind of range. However, most of the models to date are actually showing a little bit of a flattening of the curve, and I think that's important probably for 2 reasons. Number one, we are in that critical window post the Labor Day holiday where we would have expected hospitalizations to start to rise. And if anything, they're kind of holding the fort at the moment. Number two, and possibly more importantly, is there has been renewed discussion / uncertainty as to whether or not we are getting into that herd immunity kind of status. And so with the rate of infections that we had amongst the unvaccinated individuals, there is some potential that we do have some relative herd immunity at this moment, depending on how you want to define herd immunity and how you define the case rates that would be consistent with herd immunity. We're probably not quite there by what I gather is the classic definition, but we're starting to get closer, it appears. So all that's a long way of saying, I think while the COVID rates are probably holding steady and not increasing or decreasing at the moment, what we are seeing is that pretty much across the board, at least in the hospitals, the census is at once again, a pretty reasonable high. If not quite at an all-time high, I would say, but it's starting to get stressful. And that is multifactorial. It's certainly part of the additive effect of COVID. Some of it seems to be a general increase in acuity, which may be due to delayed presentation of some of our older population. We certainly see that for the unvaccinated population, the average age of a COVID-infected individual in the hospital is about 48 years old. For the average age of a vaccinated individual is about 77, 78 years old. So in that group, more and more, and we've talked about this previously, if you're not over the age of 75 or immunosuppressed, it is extraordinarily unlikely that you get admitted to the hospital if you are vaccinated. Whereas in the unvaccinated population, we're seeing a much broader scope of relatively healthy younger individuals. So with that group appearing in the hospital with some delay in care seemingly fueling hospitalization amongst the older population who does not have COVID, and with decreased staffing in the hospital setting, we're starting to see a little bit of a crunch. Well, not a little bit, we're starting to see a lot of a crunch across the region. And especially in some of those higher end staffing areas like ICU, we're starting to see a reduction in available beds across the region due to an unavailability of nursing. At the same time all of that is going, I'm sure many of you are experiencing, traveling nurse agencies in particular are doing a wonderful job of pilfering nursing staff. I know several folks have mentioned this as a problem. And so, we're dealing with staff being offered somewhat exorbitant rates to travel and leaving their current roles. We're dealing with hospitals with decreasing status or decreasing staffing because of folks retiring early, wanting to leave before the vaccine mandate kicks in, or pursuing some of these traveling options. And we're still seeing a relatively high census of this unvaccinated group in particular. So I think the next week or two are going to be critical. We know the mandate officially kicks in on Monday. So we're kind of anticipating what that will look like with staffing. I think almost every hospital still has a relatively small but real contingent of individuals who have not yet put in any type of exemption and also not yet consented to or signed up for vaccination. So either they're going to wait for that 11th hour and get vaccinated, or they, potentially just will not come to work on the Monday. So, we'll have to see how that plays out in the coming days. There was, for those who are kind of following the mandate, there's been a lot of question and I'll say uncertainty about exactly what the mandate in this court case allowed. So many folks have been confused that the court case overturned the entire mandate. That is not the case. The temporary restraining order that was issued as a part of this court case is solely focused on the religious exemption, such that because New York had not put in a religious exemption, they had to allow for religious exemptions in the mandate, and reasonable accommodations had to be made for those folks who invoked a reasonable religious exemption. So that is the crux of the court case right now. That was supposed to be going back to court for a hearing on the temporary restraining order on September 29th. We just learned a couple days ago the judge has extended that till October 12th. So there will be no more movement on that temporary restraining order until October 12th, when that goes back for a hearing. And then it's truly anybody's game. But the anticipation is, if that temporary restraining order were to be lifted and the religious exemption be overturned, that all the other cases, there were 6, all the other cases that had been basically thrown out because a decision on a similar case had been rendered would potentially get reactivated, and we could start this whole process again. So we'll have to kind of see where that plays out in the coming days, but no doubt in the weeks ahead, we're going to see a lot of litigation around the mandate and the exemption clauses pursuant to it. But the mandate in its entirety will go into effect as of Monday, but with the religious exemption restraining order as outlined a couple seconds ago, which that restraining order will hold until October 12th at the minimum. So that's where that stands currently. For those who are seeking to get vaccinated, both between the medical centers, all opening vaccine clinics to try to be as accommodating as possible to healthcare workers. The state has opened up a number of additional pods to try to get folks access. Thankfully, even though Johnson & Johnson remains in the shortest supply, there is availability for all 3 vaccines within the community at large at this time. So if there is someone who wishes to get vaccinated but will only do it if they get a certain vaccine, all of those options are on the table at this moment. So that can be accommodated. The other thing that I know has come up repeatedly is in regards to the monoclonal antibody treatments. So that was being distributed by the state. We had talked about, and some of our practices had pursued getting monoclonal antibody for administration in their practice. The federal government has now has centralized that process again with the monoclonal antibodies. So I believe that is only effective for the Regeneron monoclonal antibody. My understanding is there may be another monoclonal antibody, which I can't remember which one it is, that is not in that centralized distribution process at this moment. So there is still some uncertainty about maybe I can access this one, I can't access that one. I think the distribution plan is still being rolled out largely, but I do think we'll be getting some clarity about ready access to the monoclonal antibodies again. I know even the pharmacies at the hospitals, which had been experiencing a fairly steady supply with this centralization process to the federal government, had created some uncertainty and some reduction in availability of supply. So I know the pharmacies are working through that, and I have not yet heard that that has been resolved. So I anticipate probably in the next couple of days, that process will once again have a little bit more of a streamlined approach, because as a community, we were administering quite a bit of monoclonal antibody circa about a week ago, and that has dwindled just as the availability in the region has dwindled a bit. But that should be a temporary decrease, is my anticipation and understanding. So there's that. Testing, I know several folks have asked questions about the Cepheid and Roche systems and doing testing in the offices. And it sounds like the vendors must be doing a really good job of starting to reach back out again. I will tell you pretty much across the board, as I understand it, the reagents are still an extraordinarily limited allocation. So it appears that they are selling the machines, but they do not have the reagents readily available. And I say that even amongst the hospitals, the Cepheid system in particular, which seems to be doing the best job of marketing the units, the allocation of reagent kits has still not kept up pace, where I can tell you at Noise, I think they got 10 kits last week. So it's still questionable about what the value would be unless you could make the value proposition in your practice for using those units for other testing in your office aside from COVID. If you can make a value proposition for that, then obviously as the allocation hopefully picks up, then the COVID would just be an icing on the cake. But we've now been talking about the allocation of reagent kits for these point of care testing units for months and really have not seen the allocation pick up. I will say there was some mention, I've not seen it invoked yet, but the president or someone in the president's administration had talked about invoking the Defense Production Act to increase the availability of these point of care kits and units, and specifically citing the need for having this testing availability for schools, colleges, and the like. But that I have not seen come to fruition. I have not heard that specific order has been placed yet. So I do not think the Defense Production Act has been invoked for these units and allocation or reagent as of yet. So we'll keep you up to date as we'll hear more about those topics. I think that's the gist of what I wanted to convey. I'll shut up for a second. I'll let LJ talk, and I'll see if anything else comes to my mind.
I don't have a whole lot to add, Chad. Many of you have reached out with your concerns about not having test kit availability for the Cepheid machines, so I appreciate that you brought that up. I think that the one thing I wanted to mention in terms of the return to school documentation. So I first of all, I'll just say I recognize that your practices are overwhelmed with kids with illness symptoms right now, and many of them needing to be tested for COVID and requiring the return to school release after you've seen those kids. If you are assigning an alternate diagnosis, it is really, really important that in addition to saying this child's symptoms are due to X, and that COVID is not suspected. And please remember, if a child has any kind of a viral respiratory symptom, unfortunately right now you still have to suspect COVID. So that's not an out, but the schools actually need that little piece of information saying, and COVID is not suspected. My patient has migraine headaches and COVID is not suspected in this case, because apparently parents are having to circle back around to practices. We're just trying to improve that communication. I think the other piece is many of you have reached out where it feels like there's still discrepancy between what's happening in terms of what may be told to parents or students from school nurses, and that it seems to be out of line with workflows that we've tried to establish last year. There are many new school nurses actually in places, and so we're trying to do circle back around and holding some sessions for school nurses, both within Rochester City School District, but within some of the outlying areas too. And there has been some information that came around symptom assessment that schools could do that is a little bit confusing, that came down from state DOH. And so we're looking at that and just trying to clarify. So if you can keep your questions or your concerns coming by email, it really is helping to inform these back conversations, and we'll continue working on this. It's, it feels a little bit like we stepped back into last fall. It should be easier than that, but the volumes are a lot higher, and it's not easier than that right now. So we're just trying to get as much alignment as possible. And I think there's some messages that went into the chat, but I couldn't read them and talk at the same time. So I'll take a look now.
Yeah, so the big question, I think, from Minden Peds was that Ontario County schools are doing PCR testing for weekly teacher testing, but also symptomatic student to return to class. Do we have any information about their process?
I do not, but that is a great question. Thank you, Minden Peds, and we'll look into that. We've been this is actually super helpful. This isn't like playing police to anybody, but like if we can figure out the workflows and then share that information with you, I can tell you right now, we're working on some things right now with Wayne Central Schools too, just to understand the process, and then we'll share that out. And if we can, we will try to share out specifics. Again, not calling people out, but if somebody's got PCR testing available, let's understand the workflows. In general, the recommendation has still been for the children to have a healthcare assessment and then testing. But the numbers are getting so high, and I know your practices are getting overwhelmed, and you're having to now start to send out tests again. This is not where we want to be. I'm sorry, I just have to say it's not where anybody wants to be. And I think if we can just keep communicating, we'll do better than have everybody kind of implode.
And I will take the next one from Dr. Connors about the boosters. So boosters are still available for 65 and older and immunosuppressed, and still pretty readily available in the community for anyone else. So that younger contingent and or healthy contingent, the boosters, there's a CDC subgroup that is meeting, I believe, today to make 4 final recommendations on whether or not boosters will be approved for the general population. So I think up to and including this moment, anyone in that 65 and older category, as long as they walk into a pharmacy or any vaccine administering area that is providing the booster shots, which I think is almost everybody, maybe sans the hospitals at the moment. I think even the hospitals may be doing it in some of the clinics. And they attest that they meet those criteria, being 65 or older and or immunosuppressed, they can get their booster. For everyone else, it is still unclear. There's probably more data as far as what I've seen saying that the boosters may not be of necessity at this time, but there does seem to be a groundswell of support for doing boosters roughly 8 months after the second dose was given. And that timeline would have been September 20th, but everything's kind of on hold, awaiting September 20th, at least for our area, would have been the earliest that someone would have needed that booster. And I think depending what comes out of this CDC group today, I believe the meeting is this afternoon, we'll likely start to see a little bit more motion in that regards. On that topic, I should bring up that everyone's probably aware, Pfizer released information earlier this week that showed that they achieved a robust response with minimal side effect profile in the 5 to 11 category in the patients that were tested. We knew that they were getting close to completing that data analytics and sending that to the FDA for final review. They have not yet submitted an addendum to their EUA for FDA review and approval, but the estimate shifted from end of October to now sometime between mid-October to late October for possible availability of Pfizer for 5 to 11-year-olds. And I believe the president in some speech earlier in the week said that the federal government was gearing up to be able to offer or to get 5 to 11-year-olds vaccinated by Halloween. That was a goal that they were kind of putting forward. So I suspect we're going to hear a lot more about that in the coming days. I anticipate Pfizer must be completing their internal review of the data and will likely amend their EUA submission shortly. If history holds true as to how they did with the 12 to 16-year-old population, once they started making that announcement, it was days until they had made their EUA submission to Pfizer. So most likely, I would say by early next week, we will likely hear that Pfizer is either submitting or planning to quickly submit that EUA for 5 to 11-year-olds. I still understand that the Moderna availability will likely be the end of the year at this time. 11-year-old, 9+ month olds that could get full dose soon versus half dose now. Ooh, I don't know anything about that, LJ.
You got me on there.
Yeah, my understanding is you had to be, I don't know about that, 11, 9+ months old.
I've not heard anything in that space whatsoever. Someone else is more knowledgeable. It's on the call. Feel free to unmute and speak. And if not, I mean, this would be, I think, a question for our pediatric ID teams, especially because they've been involved in the vaccination studies.
Yeah. But yeah, that one's news on me. I didn't know anybody was getting half dose right now. So,
Justice Pete, do you want to clarify? Is that coming out of some of the study work, or? I don't mean to call you out. I'm just not sure about the question.
We're going to brand you fake news. It's a question from a family. Oh, okay.
Ooh, yeah.
I'm definitely going to brand that fake news.
So it's Liz Walsh. I'm the one who asked the question. And the reason I asked the question is because I had a family come in and say, I hear that there's a half dose, but my child is 11 3/4. And so if it comes out before they turn 12, should they get the half dose, or should they wait and get the full dose a month later? And so like in that age range, or they go over the line between the two, which one would, they're 11 when they get it the first time and they're 12 when they get it the next time. So I just didn't know if there was anything people were saying about that.
So Liz, your question, so Joanne Cordero just messaged in the chat that a family asked the exact same question. So not sure where that's coming from, what media sort of place, but it makes me think what would be a really smart thing on our part, Chad, and Renee, if you're in agreement with this, maybe at one of our next weekly meetings, we could pull Mary Caserta or pull in Jenny Nyack, folks who've been very, very involved for Peds ID in the vaccine efforts, and just talk about what's real, what's coming in that space. And so it would be great. The other thing I was going to say, for any of you that we have not circled back to recently, to find out how your COVID vaccine efforts are going, for those of you who particularly see adolescents and children, we'd like to do that over the next 2 weeks to make sure that your processes are working well, because when this vaccine does become available, there's no question there will not be big pods set up from the state to vaccinate children. That responsibility is going to fall predominantly on smaller pop-ups, efforts in schools, and primary care. So we want to make sure that people's workflows and processes are working okay, and we know what your needs are, so that we can be requesting support for you. Because if the state's not standing up the pods, they should be distributing resources so that practices can be doing this effectively. So please be on the lookout for a little message from me or Renee, just checking to see how that's going for you, and if there's any concerns that you are anticipating. We recognize probably the biggest concern is all the issue around staffing. So
2 things I will say to that, actually. So the pods, I just heard maybe 15 minutes before I came on that someone from the Hochul administration announced that they're going to open 150 extra pods centered primarily around schools to try to get children vaccinated. So it does sound like there may be some plan to increase the state administration efforts gearing up, I'm anticipating, for kids. Two, when you mentioned this half dose thing, if I had to wager money, and I do think we should get the people who actually know what they're talking about, but I do believe one of the early pediatric, the younger children's 5 to 11 studies was a half followed by a full dose, 2-dose administration. And Pfizer abandoned that plan for all of the other pediatric studies that they conducted, is my understanding. So if I had to wager, I bet people are kind of remembering or reading this old news that Pfizer was for younger children going to do a half followed by a full. But I believe my understanding is they abandoned that and it's full, just like it is for adults. But I agree with LJ. It's probably better to get people that know what they're talking about rather than my conjecture.
It's true for next week. Let's see if I can get Jenny or Mary to join that call and give a brief, 10-minute, 15-minute, whatever, 10-minute overview and answer questions that people might have.
Perfect. And it sounds like
Awesome.
that is agreeing with me, which means it's probably wrong. So I take back everything I just said. And I won't read what she just said to me in the chart because it wasn't nice. All right. Renee, anything else you got? No? Okay.
Nothing for me.
So I think we have run the chat room. Any other questions that folks have? That looks like no. Nobody's coming off. I think somebody just disappeared. What's that? So I think somebody disappeared. All right. So that's where we are for right now. Hopefully next week, I can only imagine with the vaccine mandate starting to kick in and everything, it's going to be a tumultuous week. So there will definitely be more to talk about come next Wednesday. I suspect that we will start to see the hospitals squealing a little bit as far as capacity. I do know we are already starting to see elective cases being paused in most of the hospitals. There will likely be some more discussion about that. I believe Strong or U of R and Rochester Regional are planning to hold a joint press conference tomorrow to talk more about the mandate effects and plans going forward. So we will certainly be learning more about that. And we will certainly look forward to seeing you guys next week to update you on what we know new and different. So thank you, everybody, and have a wonderful rest of your week. Take care, everybody.